Thanks very much, and in particular, thanks to Scott Wright, who's going to talk to us about the US Convalescent Plasma Program and insights and observations. And it really is a pleasure to have Scott talk to us, and in particular get up so early for this presentation, for which we're most grateful. Scott graduated from the University of Kentucky College of Medicine in 1996, joined the faculty of the Mayo Clinic, where he is a professor of medicine in the Mayo Clinic College of Medicine and Science and a consultant in the Department of Cardiovascular Diseases. And we were speaking just beforehand about how many of us have had to repurpose our skills over the last year, moving into COVID-19. We've been very fortunate to have been working with Scott for some years in cardiovascular trials, and we've been the beneficiaries of his wise counsel, particularly in the ongoing Orion 4 trial of inclisiran, and we continue to work with him on that. He's a fellow of the American College of Cardiology, the American Heart Association, the European Society of Cardiology, and the Chilean Society of Cardiology. And I suspect that may link into what I understand from the internet to be his particular interests, international radio sports events and traveling, which I suspect has been only in the mind for the last year, not just because of the restrictions of COVID-19, but clearly the enormous amount of work he and his colleagues have been doing in the Mayo Clinic with this convalescent plasma program. So Scott, again, very much thank you to talking, and we're really looking forward to this presentation.
Rory, thank you. Good afternoon to everyone, and good morning to those at Harvard who are joining. It's a pleasure and honor to be a part of this seminar, and I appreciate the opportunity to talk about the U.S. Convalescent Plasma Study and share with you what we have found and where we are with that. This is typically what plasma looks like. As we we'll be talking about it. This is, if those of you who don't do blood banking, and I don't, this is typically what our patients are getting. Let me first thank Rory and Oxford University for the invitation to present and talk about the study that we did, and to also say it's a great honor to be a part of a seminar series named after Professor Richard Dahl for all of his accomplishments, including his foundational work that established the link between tobacco use and lung cancer, as well as to recognize that he was one of the early advocates for the NHS that you have, and to say that it's really my honor and pleasure to work with the Clinical Trial Service Unit in the Department of Population Health at Nuffield with Oxford. I've learned so much and have enjoyed working with really one of the premier clinical trial units in the world to do the Orion 4 trial. This is a required disclaimer by the U.S. government because the study was funded midway through by BARDA, and the Health and Human Services Department were required to disclose that these are our opinions, and BARDA has reviewed the slides, and the federal government has approved what I am showing you because of their funding nature. Really, what does convalescent plasma do? How does it work? This is a question we were asked over and over during the study, and we continue to be asked by patients today. It basically works like this. You have a healthy person who gets infected with COVID-19. A few weeks after the infection, they've begun to recover, and largely because their body's immune system has been able to overcome the invading virus. And they create all kinds of immune responses, including a plasma that has what we think are neutralizing antibodies to the spike protein on the virus cap. And then the plasma they donate to a blood bank center gets processed and tested, and then it can be given to one or two or maybe even three. So one donor can provide perhaps enough plasma for certainly 2, maybe 3 patients, and giving that plasma has the potential, I'm not saying it does, but it has the potential to alter their immune response and improve and accelerate their recovery. The use of convalescent plasma dates back well over 100 years. This was one of the first reports in the American Journal of Public Health in 1918 by McGuire and Redden, giving it to a soldier, I think, who had a fever from diphtheria. No, this was influenza. and showed the temperature breaking just several days after giving plasma. So this really created a lot of interest by infectious disease physicians and has for the last 100 years. And as you probably know, convalescent plasma has been tested in a number of pandemics in the 20th and 21st century, including MERS and SARS, but really hasn't been talked about widely until the COVID pandemic. In February of 2020, an infectious disease expert at Johns Hopkins, Arturo Casadevall, published an opinion in the Wall Street Journal really talking about convalescent plasma and about lessons from 1934, and talked about how this potentially could be used as a stopgap measure, not a final treatment, but an early stopgap measure in COVID-19. Now, this was well before the pandemic had been declared and before Europe and the West had seen such huge case numbers. As a result of that, a number of individuals, including one of my colleague at Mayo Clinic, Mike Joyner, and Lisanne Porofsky from New York, and Nigel Paneth from Michigan State, formed a consortium to talk about convalescent plasma and how it might be tested and evaluated, and began having weekly teleconferences and sometimes nightly teleconferences to talk about this. As you recall, from just less than a year ago, March 2020, the number of cases certainly in Great Britain and in the United States began to rise exponentially. And the FDA found itself in a position where a number of academic medical centers were asking for emergency IND authorization to salvage or draw convalescent plasma from recovered patients and then give it experimentally in those who were hospitalized with COVID-19. I remember getting a call probably a month after our steering committee of Orion 4, when I was home, from Michael Joyner. In my role as senior chair of the Mayo IRB, he wanted to talk about if he could do a small treatment study with convalescent plasma. Mike is really a NIH-funded exercise physiologist and had never done a clinical trial or tested things, but was quite an avid reader of those. So he really was open to a number of scientific and design criticisms, and really had me at least give him a lot of advice and help him modify his studies to the point that it was probably ethical and to some extent scientifically rigorous enough to safely conduct in a small number of patients at Mayo. We approved his study mid-March, if not the third week of March, and he had an EIND to treat 5 patients, or to treat not 5 patients. We gave him permission to try 5 patients as a start, as a pilot, so we would have a better sense about toxicity and could understand the mechanics of doing it. And we mandated that he had to use written informed consent. Well, as the FDA continued to get all of the emergency IND requests, and they were getting 10 to 20 a day, it seems, they found themselves basically doing a rota of call and working way into the night about having to review each of these and approve them. And they began talking with experts around, including Mike and Dr. Casadevall, Dr. Paneth, and others, about could there be a single EIND for the U.S. to give convalescent plasma, recognizing that the NIH was designing 3 to 5 smaller clinical trials to test it in academic centers that had CTSA capabilities. So the FDA convened a working group, and I remember reviewing the Hopkins studies, and they had some issues, and some of the things that I've learned from you, Rory, I was able to urge them to incorporate in their design and their trials. And they, of course, were having input into Mike's protocol. There also were reports coming out in late March about, sort of 1 or 2 case examples of using convalescent plasma. Here you can see a report by Todd Ackerman about Houston Methodist was the first hospital in the U.S. to try convalescent plasma, and some of the local blood banks in those centers were getting mobilized to do it. And the FDA really was feeling, I think, a lot of pressure. They have a limited number of staff, and they were getting lots of push to look at testing at that time, to approve under EUA testing kits, to talk about the designing the vaccine approach to COVID-19, and they were dealing with a lot of EIND work, which essentially they were seeing the same protocols written over and over with the EINDs from various hospitals. So this is really how it started. The FDA decided that it wanted to create a single nationwide emergency IND to provide convalescent plasma to hospitalized patients in the U.S. and approached us to do this because they liked Mike's protocol best. And Mike recognized quickly that this was going to be much bigger than he could do, and he and his 3 or 4 postdocs. So he asked my assistants to help understand and design how he would do a network, how we would manage such a study, and how we would interface it with the necessary regulatory oversight. At least at Mayo Clinic, and I'm sure at your institutions as well, we try to keep a fairly tight rein on investigators who have INDs and other regulatory issues to keep them in the compliance zone so that they don't get into any issues with FDA and OHRP. One of the early things I did in the study is on a Monday, I put a call into our chief legal officer at Mayo Clinic, who I report to in my role as Director of Human Research Protection, to alert him that the Mayo Clinic IRB was willing to take on the role as a single central IRB for the United States, and to ask him if he had any concerns. And he immediately asked that we conference in our physician CEO, and we did. And that was probably the single best thing we did, because suddenly we had the resources of Mayo Clinic. I made an ask at that point to our CEO, Gianrico Ferrugia, and said, you're supporting us doing this. We need access, please, to research, IT, to web design, to all kinds of things, regulatory support. And we had been, basically were given carte blanche to use the resources of Mayo Clinic to make this happen. And I will say at this point in the study, there was no federal funding. FDA had suggested BARDA might provide a $700,000 to $800,000 grant, and we were willing to do this at our own expense, just to try to help be a part of the national response to COVID-19. So this was a big step for the Mayo Clinic IRB to take on what we thought would be 200 centers or so. We have served as a central IRB in an academic role for academic initiated studies, largely NIH, and to provide regulatory oversight. But I think our team was ready. I'd been preparing them for some time as the director to be ready for this, and thankfully they were ready. We also have a wonderful Office of Research Regulatory Support, and we were able to embed a senior specialist from that office into the team. So every day he would review everything, reports coming in at SAEs and things, as well as helping Dr. Joyner and the team stay compliant. And on March 30th, on that week, we began work. Once we got permission from our senior leadership to start using resources, the first call I made was to IT to try to get us set up with a website and to move ahead. And on April 1st, the Mayo Clinic IRB, absent my participation, since I was quite involved with Dr. Joyner at this point, approved the first draft of the convalescent study. Now, the FDA, Dr. Marks and Dr. Joyner and I and others had a number of phone calls, and I was really more keen, frankly, and pushed Dr. Marks to let us do a randomized clinical trial with a comparator, a placebo or another comparator, instead of simply using the model of an expanded access program. But Dr. Marks and the FDA were fairly adamant that it had to be an EAP for a couple of reasons. Number one, I don't think they wanted any interagency competition with NIH. NIH was going to fund and manage, I think, 5 randomized trials across the U.S. at some CTSA sites. We recognized those trials would be small, but with the people doing them would be well managed. FDA also felt strongly that this was a situation where a number of patients might not be willing to be randomized, and they wanted to be able to offer something that at least was thought to be safe, maybe effective, maybe not, but at least offer it to patients in hospitals who weren't willing to be randomized. They also wanted it available to any acute care center, and that's a key phrase, because if you can recall, there were plans being made in March and early April about having tent hospitals in places in the U.S., especially the Northeast Corridor and New York, for example, where hospitals were being overrun with, intubated and acutely ill, critically ill patients. And we realized that the EAP practice would largely follow clinical norms. Doctors and healthcare providers were accustomed to ordering plasma, and it would simply be if we followed the standard clinical protocols of having them go through their respective blood bank to order plasma, having the blood bank order the plasma from national blood donor providers, that it would really be the safest mechanism to bring an experimental therapy to these hospitals and these patients. We also recognized that, at least from a U.S. standpoint, there were some challenges with setting up a randomized trial in March and April. We had a nationwide travel ban basically going into place. We didn't understand how we could do GCP training of a large number of sites and how we could get them trained very quickly to get on board. And we weren't using electronic means as much as we are now. There also was significant concern that sites that had disadvantaged patients or populations that were suffering disproportionately might not participate in an RCT, at least in the US. We have a historic tradition of many of our minority communities having fear about RCTs, and we haven't yet overcome that fully. And we recognize that for a comparator, whether it would be non-convalescent plasma or anything else, as well as the investigational agent CP, we just didn't have a supply. And for the first week or two of the study, the blood bank community struggled with how to set up the acquisition of convalescent plasma, right? Because they have well-established pathways for donation of blood, but those are for generally healthy adults or adults who don't have a communicable disease. And so how do you bring someone who's got who's post-exposure, post-recovery from an infectious disease that's somewhat lethal, 2 to 3% mortality rate, that's highly contagious and highly feared? And so they needed some time to set those up. And those really were the challenges early on, and was why the FDA did not give us permission to do an RCT. They also, I think, were simply just getting overwhelmed with the request for the EINDs and really wanted us to move ahead. We negotiated some important things with FDA that I think made this successful, and I want to credit Dr. Collins and his team at the Clinical Trial Study Unit for what they have done with the digital NHS. I have watched how they do clinical trials through the digital NHS. It's one of the most innovative systems I've seen. It's facile, it's not easy, but it's much quicker, and I think much more user-friendly than how I see us doing it in the US with our sort of heterogeneous healthcare system. And so we wanted to replicate, Rory, what you and your team had done at Oxford as much as we could. So we negotiated with FDA up front the IRB reliance, which often involves several weeks of negotiating between a center's lawyer and the IRB's lawyer or technicians and staff. We said that it was a take it or leave it proposition, that we put our credentials and certifications on the web, and that you could check a box and rely. And if you couldn't rely on the IRB, then and use the central IRB, then it was you were not in the study. The FDA backed that because they didn't want unnecessarily bureaucratic delays. We also wanted ways for investigators to sign up and to be able to be credentialed very quickly. We wanted an online data entry source. We were quite familiar in FASA with using REDCap. I had recruited 2 PhD scientists who do a lot of biobank studies to work with us. I called them on a Tuesday. They signed up on a Tuesday. By Wednesday, they were developing data forms. And we have an entire support structure for REDCap. REDCap is not necessarily FDA compliant for most clinical trials. The FDA waived that compliance requirement for this study. We also said that if we have to collect paper forms, the 1572s, it will slow things down. Can we develop a web-based 1572 that auto-populates all of the affirmations, and then the PI has to attest and sign? The FDA said, yes, we prefer that as well, so we did that. We waived the typical GCP training because we felt that all healthcare providers would understand how to give plasma or have support to give plasma. We also required that the principal investigator at each site be a licensed physician. So nurse practitioners and PAs were not allowed to be site PIs, but we needed a licensed physician in that state. And then the FDA made a very innovative request, maybe a mandate. They said your consent form has to be 1 page, and they wrote what they thought was a sample consent form. Well, of course, as you know, consent forms can go through an IRB and come out looking much differently. And we eventually agreed between the Mayo Clinic IRB and FDA to have a 2-page consent form. Then we ultimately learned that we had to make the consent form due to the nature of the study into a number of languages. So we were very flexible with how we got this translated and gained an appreciation for the cost of what it takes to translate and make a change on a consent form. We also felt that paper might be a method of COVID transmission, and we did not want to promote that, so we said that any written informed consent would need to be digitized. We preferred that it be digitized at the patient's bedside, either through a document scan or a photograph, or put it in a Ziploc bag and zip it up, and after you do the photograph, but do not send it to us, keep it there. We allowed legally authorized representation consent, as most states in the US allow. And then we reached a point where we had patients who wanted to consent but could not, and were in situations, unique situations, where they had no LARs. And we had situations where we had maybe one elderly person in a hospital in South Florida. The second person, their spouse or significant other, was at a home 40 miles away. The hospital prohibited visitors. They couldn't get in. They didn't have email. They didn't have web access. All they had was a telephone. And so we had incarcerated individuals who needed to be enrolled in the study. So we used after discussions with FDA, agreed with HH Secretary's guidance for the emergency use of consent using 2 physicians, 1 non-affiliated, for inclusion. The patients in this study had to have severe or life-threatening COVID. They did not have to be in the ICU, but they had to be considered at risk for progression for seriousness of the COVID. So here's the timeline. On March 30th, FDA reached out, and Mike Joyner called me that day. I was keen to do it because we wanted to be able to try to help with the COVID pandemic. We got it to the IRB, and mostly in March and April, we were meeting weekly, if not daily, as an IRB. I convened ad hoc board meetings, sometimes 2 or 3 times a week, sometimes several days in a row, because we did not want IRB review of protocols to be a delay for moving science ahead with COVID. So our IRB was very facile. As a background, we have 4 independent IRBs at Mayo. I serve as the director of it. So I have 2 co-chairs that I appoint to each of the 4 boards, and we have about 8 to 10 members, including community members, scientists, and non-scientists. And for the ad hoc IRB, we pulled community members and non-scientists from our 4 boards, and then I asked each of the 8 co-chairs to serve on the ad hoc, and I chaired most of the ad hoc meetings so that we would not disrupt the routine work of the IRB, but we also could provide very timely service to the scientific community. Because we were furloughing many of our employees at this point, or they weren't so busy, shall we say, because we had closed our outpatient practice and were doing minimal inpatient work in early April, we had a lot of excess FTE. So we were able to grab that, take research IT, and they built our website. We were able to take the REDCap team, and they were able to work with our scientists who were devising the data forms. We used the Joyner postdoc fellows, who were all PhDs, to be our communications center, and we had 3 clinicians one in cardiology, 2 in anesthesia critical care, who had excess time, and they agreed to serve as physician navigators and to call sites when the specific questions came up. And our website was finished on about the 3rd of April. We had people finding this website before we somehow got it publicly released. I don't know how, and several centers had already signed patients up even before we had publicly decided to go forward with our website and our study. I've never ever encountered anything where you have a research study and sites are looking for you instead of you looking for them. The FDA goal of the entire expanded access program was 5,000 patients. And we had agreed that it would be a pragmatic study, that we would use an expanded access platform, but this was a research study, that we wanted to look for safety and effectiveness in terms of how we delivered it, but we also had an exploratory endpoint for efficacy. And much to everyone's surprise, the goal of 5,000 patients was quickly met, and the ultimate enrollment ended up being a little over 105,000 patients. So when we planned and started this, we thought we would be flying maybe a regional plane with about 40 passengers, right? But it took off like an Apollo 5 rocket, and we were just quite surprised at watching this. There were days in the summer, as you can see from the enrollment here, that we were seeing 1,000 people a day enroll. And I just marveled at that and wondered what we could do with some of our randomized clinical trials to bring this kind of enrollment. And I will say that in hindsight, I think we missed a real opportunity in early June because we had published 2 papers by now. We published one about the 1st of May in the Journal of Clinical Investigation on safety, and one in the Mayo Clinic Proceedings on safety and tolerability. We talked with FDA at this point about converting this to a randomized clinical trial, and I think we missed an opportunity, at least at some centers, to convert this to an RCT with a comparator arm or placebo, as the UK has now done, to better test this in a more rigorous way. Here you can see the enrollment by region. Early on, we were enrolling a lot of patients from the Northeast. That's in light green. You can see that from maybe 50% of our patients came from Northeast, mainly New York City and Boston and that area. And then as the summer came, the Southeast and Southwest, where the COVID pandemic just really took off, started enrolling patients for us. And then we ended, of course, in late August at the time of the announcement of emergency use authorization. Here's a graph of the hospitals that we covered, and I will say that the study was not limited to the continental United States. We had major hospitals in Alaska, Hawaii, Puerto Rico, and in every U.S. territory and military base, including sites as far away as Japan and the Mariana Islands. So we had no idea when we went into this that it would be such an extensive network. Here's a graph of enrollment you can see going forward between the 1st of April and the end of August, showing as the colors get darker, those are the states that are enrolling, the numbers of patients that we had. And you can sort of follow the pandemic from April to August by just looking at the enrollment, as you see there. It starts in the Northeast, and then it suddenly spreads a bit to Illinois, and then into California, Texas, Florida, the Southwest, and then it's going to pop into the Midwest part of the United States in the later part of the summer and early fall. We looked at whether we had every U.S. hospital involved in the study. We thought we only had one hospital region that was not involved, Bloomington, Illinois, but we learned that later that we had 5 hospital referral regions that did not participate. So short of that, we had every hospital referral region in the United States and in its territories involved in the study. And I think we achieved one of the goals of the FDA, which was to make convalescent plasma available to as many hospitals as possible. Here's an example of a slide that our biostatistics team made for us each week with the study, and I'll just walk you through this if I may. Let's look at Wisconsin. In yellow, you can see the peak of the pandemic in terms of the number of positive diagnosed tests, and then in the orange or light orange color is the use of convalescent plasma. So in Wisconsin, during the first peak, there was not much use of plasma. In the second peak, they started using it more and more. Now let's go to the right on my screen and look at New York and Massachusetts. You can see that early on, there was a lot of COVID infections, and those 2 states saw the brunt of COVID in the U.S. in the spring, early spring, and then they got it well under control. And they used convalescent plasma sort of in a time-delayed fashion, a bit of a shift to the right of that curve. And then as the pandemic diminished, they were able to stop using it so much. The same is true of New Hampshire and Maine and Vermont. New Hampshire was a special case. I'll talk about that for just a second. New Hampshire had passed a law to protect patients against experimental therapies. And they wanted, the New Hampshire law required written informed consent for the use of plasma. We had 2 patients at one of the New Hampshire medical centers in southern New Hampshire who were both critically ill in the ICU. One was intubated. They were not able to give written informed consent. Their families were begging the hospital and the physicians to push them into this study. We had to make phone calls and eventually between the Attorney General and the Governor of Massachusetts, they were able to issue an exemption for the COVID-19 pandemic for this law, recognizing the mistake that they had made, I think, in passing a law that prohibits patients from ethically entering studies when families or others can give appropriate informed consent. I'll also point out, if I may, that in the Midwest, where I live in Minnesota, you look left to the Dakotas, even Montana, the Mountain West, the pandemic peaked later. And even in the late summer and early fall, we began to see the worst of us in South Dakota as well. Why were we successful with the huge enrollment and minimal issues with sites? Well, there's nothing special that we did, I think, in terms of recruiting patients. This was a study that had its own built-up demand, and people wanted to do this. Hospitals and patients wanted this, and we were simply trying to stay, 30 minutes ahead of the demand in a sense. But we had a strategy of trying to simplify everything. we recognized early on that we were dealing with incredibly busy clinicians, nurses, study team members, and we wanted to minimize any time they had to spend on paperwork for enrollment, data reporting, and compliance. We had calls early on from physicians and nurses who would eventually call and speak to one of our physician navigators in tears, they had physician colleagues who were dying of COVID. I remember poignantly 2 examples, one from North Carolina, one from Louisiana. They wanted something done. Could we possibly help them find convalescent plasma, because the blood collectors had just not delivered much plasma by mid-April. And it was a very tragic time, as I'm sure you've experienced in the UK as well. We revised our data reporting form a couple of times to try to make it easier. We had a test case in New York. We had some of the hospitals in New York had a number of employees who could not be furloughed. So they were converted to doing the forms, and they gave us important feedback into late April, early May, and we took that and tried to change our form so that it was simpler for them to enroll the patients. We felt that we should make compliance with the regulations and the study requirements a default option, and we pushed people into that. We only had a small number of non-compliance issues that rose to the level of serious non-compliance. I think less than 6 in the entire study. We also had a single consent form that we said you could not change. You certainly could tailor it or customize it for your hospital, recognizing that many of them wanted to put their hospital name and logo on and their physician PIs. We had no trouble with that. Initially, we translated the consent forms into the languages, Arabic and Spanish and just French and just a number of languages. And then eventually, that was becoming quite expensive for us. I think it was about $600 to $700 an hour for our translation services. So we started saying to the sites, why don't you have a native speaker translate it, and then we would have it validated. And we were able to expedite the translations into Mandarin and other dialects that our West Coast centers needed. We really directed all communication through the web and email, and as a last resort, the telephone, because telephone, as you know, there's a fixed number of calls you can take per hour, and we didn't want everyone tied up. And we worked with our communications team to have responses that fit scenarios. So we created FAQs. From a regulatory standpoint, I would give them tons of guidance and would create a number of not canned responses, but unique responses to common questions to try to help sites stay within the regulations and to finish their work. And this communication center was staffed by very talented young PhDs and a couple of medical students and residents who just really rose to the occasion and handled all of the massive communication. We had a decentralized leadership style on this. Mike Joyner was a wonderful motivator, but he recognized quickly that he didn't have the entire skill set to lead the study. He had a part of it, so he delegated a lot of things to several of us to work with him, and then we empowered those working on our teams to just make decisions and move ahead. And I think to a person, everyone put their own personal research agendas on hold and just worked like crazy on this project. I remember in mid-May realizing I'd worked 16 to 18 hours a day every day of the week from the 1st of April or before on this project. And I tried to get Mike to take a weekend off at one point in June or July, and it was, I think, August before he agreed to do that. We also recognized the need to reach out beyond the traditional medical community for collaboration and assistance. We really hit a stumbling block early on with plasma donations. And I was on calls with the FDA, with American Red Cross and other big plasma collectors, and they had some challenges. And then we figured out that they still were having some trouble finding donors. So donors recruitment had to be tailored to some extent to the culture and region that you lived in. We had a colleague in New York City who did a lot of medical management or helping members of his religious community find physicians. And so he's a huge shoe wholesaler, and he got involved in this and designed some retail and wholesale business tactics that really resulted in the collection of tens of thousands of units of convalescent plasma. And once we figured that out, in the Midwest, we used our medical students at Mayo Clinic to reach out to anyone who had tested positive for COVID. So we were getting lots of plasma donations from willing members of the community. And we even set up special donation sites because obviously people who have had COVID, you need to be separated a bit from those who have not been exposed. I do want to thank FDA and BARDA. BARDA ultimately provided the funding, a large grant of about $40 to $45 million in May after reviewing our protocol. We had every week calls with FDA leadership from Siebert, Dr. Marks, Dr. Verdun, Dr. Witten, and others. There were many times that we were on the phone with FDA attorneys, FDA Office of Legal Counsel, FDA Office of Regulatory Affairs, and the analysis that I'll show you in a few minutes was a back and forth at times between our statistical team and FDA until we had agreed upon maybe some preliminary analysis for the study. The secret of having these weekly calls with FDA and BARDA and sometimes daily calls, which would come often at 6 a.m. Central Time for me, was that we could get the right people together quickly and solve problems. Now, this is probably not a model for everyday work, but it was delightful during a pandemic to just get problems solved and move right on. And Dr. Marks, to his credit from FDA, did not shy away at all from making decisions and really was instrumental in making this happen. Again, I want to tell you that I learned a lot from observing how things are done in the clinical trial study unit with the digital NHS work. And this sparked some creativity at our place as I talked about that and had our site dream about how we could try to replicate that. The only thing we lack in the US is a single unified electronic medical record. And of course, we have some legal obstacles to get access to that. But we did work in consortium with Cerner and Epic, and I will say that those were very intense efforts that continue to be worked on to this date to try to figure out how we could replicate what the digital NHS is doing. And I also have to say that had Mayo Clinic leadership not given us sort of carte blanche access to IT support, database creation, web sources, and research and regulatory support, we would have really been in trouble. So we tried to organize things so that treating clinicians could get on the web, get a question, and get an answer back same business day, or get a phone call. And the physician navigators were crucial. These were all senior level physicians who had lots of experience with critically ill patients who actually had ordered convalescent, not convalescent, but non-convalescent plasma, lots of blood products, who had real world experience in doing this. And they were the interface between our research management team and the sites, and it made a huge impact. And we also took feedback from our sites. And when the study ended, of course, well, not ended, but during it, we tried to have workflows for physicians. We constantly rethought our website. So here's an example. We put on a workflow. Our web team did a marvelous job coming up with what we thought were simple, easy steps, helping people understand how to do it. So this was under helpful information for physicians. You've identified a COVID-19 patient who's a potential recipient of convalescent plasma. So the first step you did was register your site using our site registration form. And then you had to register yourself as a local PI and then fill out the 1572 form. And then once those had been properly filled out, and we had sort of what I called idiot-proof IT algorithms there, so you couldn't move on unless you had properly filled it out. If you hadn't properly filled it out, it highlighted where you had failed with filling it out. And so I wanted something that would allow a sleep-deprived, exhausted healthcare provider not to have to guess at what they were missing, so we could show them the information they were missing. And then they had to obtain patient consent and verify that they had it and keep a signed copy of the consent form or dictate a note to file for emergency consent authorizations at their local site. And then we had a patient enrollment form, and they would submit the form online. And then they got a verification back through a pop-up notification, and then eventually through an email confirmation that their patient had been enrolled, and then an order was sent to their blood bank acknowledging this to allow the blood bank then to place an order through a national blood distribution group for convalescent plasma. We also had a lot of FAQs that we thought were helpful to physicians. We had a quick reference guide that we created to show them. And again, this was just very clever creations by the web team that we were given, our research web team. We even developed some video tutorials by those who had designed the forms, who explained how to use them and how to answer them. And like I said, we took a lot of feedback from our sites, and And the number of forms we reduced online, the fields of enrollment we reduced, the total fields without SAE reporting we really cut from about 200 fields to 60. And initially it was taking them about 90 minutes to complete a study data form completely, and we reduced that down to 15 minutes. This all happened in 1 week in July when I was away on vacation, and I have to say with some degree of observation that I think perhaps this got cut just a little too much. I would have urged them not to. Well, as you probably followed in the news and watched the whole drama from July until late August about whether the FDA was going to issue an emergency use authorization for convalescent plasma, it happened on August 23rd in the evening. And we knew about it about 48 hours ahead of their announcement. We knew that they were considering it for some time because we would provide data to them. We would get calls from FDA. We were certainly alerted. It was interesting to see that the Center for Medicare and Medicaid Services had issued a payment code in July for convalescent plasma, but that preceded the EUA by about a month. But we talked with FDA about how we would transition out of this study. By this point, when we ended, it was 105,000. We were certainly between 90 and 100,000 at this point when they were talking about within 48 hours of the EUA. And we thought that there would be no reason for the expanded access program to continue once an EUA was done, but we didn't want to leave the hospitals high and dry in the sense of cutting it off on the very day of the EUA. So a week after the EUA was announced, we did stop the program, and we gave everyone time and announced this. What we learned is that while RAVE is an FDA compliant software that allows clinical trials to gather data, REDCap did an exceptional job, and it facilitated the transfusion for about 95,000 patients. It was easily modifiable, scalable, and was easy for our team to use and very easy for sites to enter. We had no data theft to our knowledge and no concerns about loss of privacy at this point. It has an intuitive user interface. Our website did as well with secured links. We wanted a system that was simple, quick, facile, and as transparent as possible. So a physician would know that she or he were enrolled. They would know if their patient had been approved, and they would know that an order could be sent to the blood bank for plasma. We also learned that, with all clinical trials, that local site coordinators are key for data entry and corrections. We had site payments that went to sites, and a number of sites really had a holdup on their payments until they finished the last few elements of data. And we really found the site coordinators were the key for this. And that our collaboration model that we used for this study worked, at least for us, because we had our oversight committee, sort of our executive steering committee. We had the data integrity team that challenged things, our regulatory group, statistics, project managers were eventually brought in to help us manage the enormous volume of work. So our charge really was to provide access to convalescent plasma, and the secondary objective was to determine was it safe. And then we had an exploratory endpoint to look at whether it was maybe efficacious. So this was the first paper we published. This was late April in the Journal of Clinical Investigation. We wanted to get out the data as quick as we could. We had over 5,000 patients with complete safety data by the end of April. So this was put together very quickly, and JCI, I think, accepted it with a minor revision about a week after it was submitted. And then we had 20,000 patients by June 2nd. And I thought we should get a second paper out doing sort of a demographics, and we published this in the Mayo Clinic proceedings, and they were kind enough to push it online for us as soon as they had accepted the revision. Here you can see some characteristics. I'm not going to show you the entire study, but this is very similar to what we have in the 105,000. The patients were largely elderly, shall we say, at least a large percent were. I don't consider 60 to 69 elderly at all, but there were a lot of those age range patients hospitalized. We had about, at this time, 60% men, 40% women. That held through the study. We were delighted that we had 20% African Americans in the study because we wanted to make sure that the communities that were being disproportionately affected by COVID had the opportunity to take plasma. We had about 5% Asian, about 30, it ended up in the study about 38% Caucasian, and about 36 to 37% Hispanic were involved in the study. You can see the typical clinical symptoms, which will come as no surprise. It's just typical for COVID. And as you can see, that a great majority of our patients either were high risk of progression or were in the ICU, and about a third or so at this point were on a ventilator. We observed this interesting phenomenon in the United States. This is independent of plasma, which is that the mortality was falling on a weekly basis because the healthcare system was getting better and better at learning how to manage COVID and taking care of COVID patients. So an exploratory endpoint of our study was to examine the impact of convalescent plasma on outcomes, recognizing that we did not have a placebo or comparator group, but one a priori hypothesis was that neutralizing antibody titers might predict any efficacy that was seen with CP. Now, I will postulate that convalescent plasma was essentially randomly distributed across all the sites in really a pseudo double-blinded manner, meaning that no one knew if the plasma that was being given had any degree of neutralizing antibody measure. We didn't test the neutralizing antibody levels prior to transfusion. We simply held aliquots of blood in about 3,000 specimens. And so everyone was blinded, the study team, the blood bank team, the local PI, and us, as to whether patients were getting any neutralizing antibodies or some degree. And we published last week at the New England Journal of Medicine the sub-analysis of about 3,000 patients in whom we had plasma samples prior to transfusion, and we could measure neutralizing antibodies using a variety of methods and techniques. This is part of the data that went to the FDA for their emergency use authorization. I will say that the Broad Institute in Harvard has done their own independent analysis as well, and I think there will likely be a paper from that at some point. But you can see that the sub-study had about the same characteristics as the larger trial, about 60% male, 40% female, 23% African American in the sub-study, 47.5% Caucasian, 37% Hispanic, and a large number of them had severe life-threatening COVID. Many of them were taking medicines. You can notice there was a lot of hydroxychloroquine use. We, of course, had a political leader in the United States who was attempting to practice medicine by recommending it. And there was a lot of use of this early on. In our multivariable model, we found that this was associated with an increased risk of mortality. And you'll see that coming out later, I think, in a manuscript or a proposed manuscript. But when we look at our model, we decided to compare high titer neutralizing antibody plasma to other. And we found there was a 25% relative risk reduction using the base model without multivariable adjustments for those who had high titer versus low. And when we adjusted for varying things, including the most aggressive model, there was about an 18% overall reduction with a p-value that just, missed 0.05. When we looked at patients who were not mechanically ventilated using the base model, the second model, and then the third model, we saw, a highly statistically significant difference between patients who got low titer plasma and high titer plasma. And medium titer plasma really acted a bit like low titer plasma if you look at these data. And in mechanically ventilated patients, there really was not any outcome or any difference in outcomes, meaning that it's likely plasma was not helpful, or certainly there was no signal to suggest it was being helpful in this population. These were the variables that were important, of course: age, presence of ventilation or not, ICU status, antibody level, baseline condition, weight, days to transfusion, respiratory failure, sex, and of course the use of hydroxychloroquine, as you can see, persisted in our model. And in the appendix to our New England Journal paper, there's more data about it there. So we believe that this model that the FDA and we put together was successful in providing access to plasma during a pandemic. It demonstrated safety with a less than 1% rate of transfusion-related acute lung injury and circulatory overload syndrome, so quite safe. It was not a randomized trial. We recognize that. It doesn't have the power of a randomized trial with a comparator group. But we do believe that we were able to examine efficacy within the constraints comparing low titer to high titer. And whether that efficacy reflects real efficacy or whether it reflects less harm, one could, of course, debate. We identified a number of key risk factors that play a role in determining whether someone may be suitable for consideration of plasma, including ventilatory status. And we found, at least in our model, that these factors were probably more important than other medical therapies, with the exception of hydroxychloroquine. Now, I just want to point out that while we were not a randomized clinical trial, we did have a few similarities. That we believe the high titer plasma was randomly distributed. We had no way to know who got what, and we were blinded until after this was given. and that the neutralizing antibody levels were masked and blinded and batch processed by a central lab who also was blinded to any outcomes, and that this was pre-specified. But I think it's fair to say, especially to this audience who do trials as sort of an exceptional manner globally, that we had no placebo comparisons, but we did have everyone on active standard of care treatment. So everyone should have been on baseline, remdesivir at some point, as well as appropriate, other treatments, including corticosteroids. I think it's fair to say that there was likely bias with regard to who got offered the study, who was given plasma, both from a positive standpoint and a negative standpoint. We recognize that a number of patients were put into this study who this was considered a last-ditch effort. In fact, I had a patient come last week to see me at Mayo Clinic, and his wife was with him, and he needed to have heart valve surgery. And I started talking with him about whether he had COVID, and he said, no, but my wife did. And that, of course, raised a red flag because we're really trying to protect our practice from active COVID infections. So she said she was hospitalized in December in the ICU. And she said, you may not know, doctor, but plasma has antibodies, and they gave me something called plasma. And she said it saved me. So we're hearing a lot of anecdotal reports like that. And so she clearly was one of those cases where they told him and her that this was the last-ditch effort. And so we recognize that created some bias. But with 105,000 patients, we think some of the sheer numbers of what we think is real-world evidence maybe accounts for a bit of the bias. And I think it's always possible and important to point out that the differences we see in outcomes may reflect that low titer plasma caused harm, and we just don't know. And I think we're waiting on your randomized trial in the UK to be published to help us. This was our leadership team for the study. Mike Joyner. I was actually asked by Mayo Clinic to step in at one point as co-principal investigator. This was in the midsummer. Delisa Fairweather and Caitlin Bruno were involved as our data team. Ricky Carter led our biostatistics team in a large group. Jack Senefield is one of our postdocs with Dr. Joyner, and Jack was our communications center leader. Mark Wentworth ran our compliance effort and worked daily with us, and Lisa Munkel ran our website. We're really happy to say that the Library of Congress has decided to archive the website of this study as one of the historic mementos or historic documents for the COVID pandemic in the United States. And this gives you a much better sense of the entire group of people who worked with us and helped do this. We had twice, sometimes 3 times weekly, sometimes weekly teleconferences among our team. I want to point out that BARDA provided funding. We also had donors who donated charitably, including the Schmidt Foundation, the Schwab Charitable Fund, United Health Group, the National Basketball Association, Millennium Pharmaceuticals, Octafarma, and of course Mayo Clinic made a large in-kind donation of our time and effort for the study. So, in final thoughts, it's a pleasure to talk about this. I present it really as an observational study with our sub-analysis. We think of it as a pragmatic design and recognize that it has, some methodological challenges so that this is not the strength of a randomized clinical trial, but it hopefully is another piece of evidence that will help those who are doing trials and planning trials to look at our data and then use those for some of the designs that they do. So let me say thank you, and Rory, I'll turn it back to you, if I may, and be happy to answer questions.
Scott, thank you very much. It's really interesting not just to see results of a trial, but I particularly enjoyed, maybe it's the technologist in me, but the description of the mechanics. And I think perhaps one of the things I'd be interested in your comments on is around that. What you described was months, if not years, of design, planning, implementation being done over weeks, if not days. That'll be very familiar to people in NDPH, particularly in our National Perinatal Epidemiology Unit and the Clinical Trial Service Unit, who worked together, as well as other studies in NDPH on COVID-19, who've seen this extraordinary acceleration. So I wondered whether you might comment on the wider lessons for clinical studies, and I think you alluded to it, to randomized controlled trials beyond COVID.
Yeah, thank you. And I appreciate your comments on that, because you're exactly right. This was an extraordinarily stressful endeavor, and Mike Joyner comments that we kind of built the airplane as we flew it, and I would say you can't really do that, but you can certainly change out an engine in flight maybe. And we tried to be facile. We tried to learn from our mistakes, learn from what sites told us in terms of changing to make it easier. From a larger lesson of clinical trials, I think what I see that needs to be tested is, can we do more digitally? Can we recruit patients as you do through the digital NHS? Can we do more data collection like this? Can we eliminate bureaucracy, and can we get regulatory agencies to move into the 21st century with digital-based tools like we were able to with the 1572 online, with reliance agreements and things like that. I have a couple of daughters who are economists, and they talk about a concept of dead weight, and I see that with trials. We have a lot of regulatory steps and other steps that just are dead weight. It's delays for the trial organization like yours, and delays for sites. And can we eliminate those as a way to make things more efficient and more responsive? And finally, I'm still totally amazed at how many people signed up for this, recognizing there was no placebo comparison, recognizing that there was no strong data to support its use. And I think it just reflects the angst. It reflects the angst that we have as a culture with COVID. But it also tells us that there are groups of patients who historically are not in randomized clinical trials, largely minority subjects, sometimes women, and communities who are being bypassed because we just don't have the ability to bring the trial enrollment or the study enrollment to their local hospital to make it easy for them. And again, you're leading with that with your efforts with Orion 4, and I think it would behoove all of us to learn from that and to try to do more of like what we did, which is to get it to every place. And we wanted a system, honestly, that could allow sites to come on board when the COVID epidemic hit, right? We couldn't have picked 25 or 125 hospitals from in late March, early April that would handle the COVID pandemic because it was unpredictable. So I think with a pandemic, you have to have a system that allows sites where the pandemic, it moves around and where it's jumping to quickly get on board and to get going. And if you can't, then you're going to miss things. I like how you're doing it in the UK. You have every hospital involved in your COVID studies. We don't have a system like that in the US. It would behoove us to do that so that for the next pandemic, and there will be a next pandemic, hopefully not in my career time, but there may be one in 5 years, who knows? We should be prepared.
Thanks very much. There's a question from the audience about, is anyone looking for autoantibodies against IL-6 in the donors?
Oh, that's an interesting question. I suspect that we will. We just have roughly 3,000 or so samples of plasma. We were not able to collect a lot more than that because this was a chaotic time, and some of our blood donation centers just didn't keep an aliquot of the sample, or the blood. The hospitals did not keep an aliquot for us to use. But it's a good point. I'll bring that up to our next meeting.
So Peter Horby's on the line, and as you know, Peter, along with Martin Landre, is leading the recovery study. I don't know, Peter, if you wanted to kind of make any comment or ask questions in the light of your experience and thoughts.
Hi, Scott. Yeah, thanks for that incredible achievement there. I mean, the logistics are phenomenal. I guess a couple of questions. One is about, there's been a couple of reports of the difficulties in ICU patients. So you saw it in your subgroup, and then the REMAP CAP study stopped their intensive care based study for futility, and then we stopped ours in recovery on 7th of January for a clear lack of benefit in ICU patients. Has that changed practice in the US?
I hope so. I think we recognize that we need to do more treatments to keep people out of hospital and those in hospital from progressing to ICU. And yes, I know with the monoclonals, I've been involved in some discussions between varying groups that the thought is to try to treat now people in the ED or before they need to be in the hospital. I think Johns Hopkins is doing a randomized trial. I think it will report out soon about plasma in the ED population, but I think that's where we need to be testing. And I think you're correct. And my congratulations on your trial and its completion, because I think your evidence and data will really help guide how we design additional studies going forward to deal with this pandemic, because it's not going to end for a while.
Yeah, I mean, I think it's a difficult issue, convalescent plasma. I think because of the many variables. I mean, we have issues with standardized way of measuring the antibody concentrations in the plasma unit, standardized ways of measuring antibody concentrations in the recipients. There's many dynamics, and so I think there's still a lot to learn about convalescent plasma. As you know,
I agree, and I think that we will see papers from both Broad and Mayo Clinic which will outline how we've done it. We found an Ortho Igg assay to be incredibly helpful and predictive, and simple. We were using, and I think Broad has the appropriate BSL level to test with the live virus, but we were using other samples from a startup company in Rochester looking at COVID, and found that we could not be certain that we were getting the same types of measures each time, so we switched to the Ortho Igg assay.
Yeah. So I was wondering, actually, a question to both of you as to the merits of having these two large studies, because I mean, over 100,000 people, as Scott emphasized, provides you a lot of information about safety. And maybe, as he indicated, a kind of surrogate approach to look at efficacy, whereas the recovery trial, less patients, but you have the underlying randomization to look at efficacy. So the two together seem to be quite a valuable combination, but I don't know what your thoughts are. I mean, maybe it's Peter and then Scott.
No, I think, you know, it's going to be really important to compare them. You know, we're not using the same assay, we're not using the Ortho, but we want to validate that there's been some work to look at the correlation. I think that'd be really important so that we can match both the, you know, the plasma categorizations and also the patient populations with the observational data, because obviously, you know, we've got 10,000 patients and we've got a clear overall result, but you know, the devil's often in the detail in the subgroups, in which case we may not have the adequate power in some of the subgroups, and so looking in across to the bigger EUA program, EAP program, may be insightful.
I agree. I think we're in a global pandemic, and this calls for a global effort, and we ought to be, you know, providing data to help each other to answer the question for all of us, because we're all going to rise or fall together in this pandemic, and it behooves us to get some answers as quickly as we can to guide treatment and to deal with things.
Well, I think we're just past the hour. There aren't any additional questions that I've seen come in, but Scott, I really wanted to thank you for, I've seen the sun come up behind you during your talk. I really want to thank you for joining us today, but I think on behalf of everybody, to thank you and the Mayo and extended team for generating this extraordinary amount of data. As you say, we're all in together and we'll all get out of it together. So thank you very much for joining us today, and thank you to the audience as well.
Thank you.